Better never ends. In health, in performance, no matter your starting point, you can always strive for better. My name's Charlie Goodchild, I'm your host, and this is the Better Never Ends podcast. We've made it our mission to share with you the expertise and wisdom of role models and leading experts in their field, teaching us about how we can be better, telling stories about their journey to better, and inspiring you to discover yours.
Welcome to another episode of the podcast. Today we're welcoming Mr. Kash Akhtar. So today we're going to be talking about osteoarthritis with a knee surgeon. And hopefully we go on a bit of a journey here where we talk about the basics of what knee arthritis is, but also what hopefully we'll get to is some different ways of thinking about it to hope what most of you I reckon will be thinking. So it's not necessarily the doom and gloom, wear and tear, and a disease of disability. There's hope. And that's
I'm in the wrong place.
But here's Kash. I'll welcome Kash into the conversation. So yeah, tell us a bit about you, Kash, and why it is that you came here.
Thanks for having me, Charlie. It's nice to be here. First time I've ever been on the other end of a podcast.
Yeah.
So it's slightly surreal, kind of, coming in and not being fully in control of the conversation. So I'm not quite sure where it's going to go.
Yeah. Well, we also didn't mention, that Kash runs his own podcast. So you run Orthohub, C1, Do One podcast. I've been listening recently, and it's, if anything, I feel a bit pressured because you're doing such a great job. I feel I'm on the spotlight.
Yeah, you're very kind. It's great fun. We were chatting before this podcast. It's a real opportunity to reach people. But actually, selfishly, it's just really fun to do. And I get to meet some awesome people, probably who would never talk to me normally. In the podcast, we've just hit just over 250,000 downloads now. And last time I checked, about 4 months ago, it was 140 countries. And I can't name you 140 countries. I get to Malta and I'm like, Gibraltar? I don't know what's after that. So, it's great fun. So thank you for having me. I've listened to your podcast. I've seen it on social media. And I also said, I bet Charlie's going to be wearing a white T-shirt.
Here he is in a white T-shirt. It complements the wall, which I know you have also just complimented yourself. You like our wall, which perhaps is a strange thing to mention here, but you, as a podcast aficionado, you see these things, right? You're looking for the visuals, especially as a
you're looking at the microphone, you're looking at the branding. I'm looking at all the kit that's here. No, so thank you for having me, and I'm very happy. So it's funny because you introduced me as a knee surgeon, and of course I'm a knee surgeon. That's what I do. I'm a consultant trauma and orthopaedic surgeon who specialises in knees, but I think more of myself as a knee specialist. And it sounds a bit poncy, but the fact is I probably operate about 11% of what I see. It just happens that I see a lot, so I operate quite a bit, but the actual proportion I operate is quite low. So the surgery part is actually probably the smaller part of what I do.
Yeah, which is actually kind of slightly why I mentioned it, really. I was thinking of you as a knee specialist, but the contradiction is that we're talking about a disease that not too long ago was essentially treated predominantly with surgery. And now that's why I was keen to have you in, because I know that about you. You are very careful about who you operate on, and tell us a bit about, actually that's a good place to launch the more clinical side of things. Why is it that a knee surgeon like yourself is now operating less and less on knee injuries that come to see you?
So basically the traditional algorithm has been knee arthritis, physio, injection, knee replacement. And knee replacement is still a really effective operation. It's still one of the most successful things that we do in medicine. A hip replacement is, I think it's cataracts number one for quality of life. You can't see, you can see. Hip replacements are phenomenal. It's just a ball in a socket. You put it in backwards, the patient's delighted. As long as they don't dislocate and the leg length's roughly in the ballpark, they're fine. Knee replacement is more challenging because there's kind of 6 degrees of freedom on the knee. But the challenge is that and within knee replacement, lots of different types of knee replacement, which we'll come back to, but about 15% of people globally are not happy with their knee replacement. If we say the evidence would suggest that 85% of people are really happy with their knee replacement and got a good outcome, and it's just primarily a painkiller. It may have the secondary aid of aiding mobility, and often it does. It doesn't normally increase your range of motion, but it's a painkiller. Then you take 10% of people who go, well, actually, it's about the same, hasn't made much difference. You take 5% of people who are worse off, may have had a complication like a blood clot or an infection or a DB, a wound issue, which is rare. And some people just have unexplained pain. There are a proportion of people who have really fantastic looking x-rays where they did technically done operation. And that's the challenge as a knee surgeon. And there are lots of people who do a lot more than me. If I'm honest with you, knee replacement probably makes up about 10% of my practice. And the thing that I find that I do quite a lot of more proportion of partial knee replacements, and I find those to be much more rewarding and more predictable than total knees. And total knees, there are a lot of surgeons doing them, and it is a really good operation for the majority of people. But the proportion are not happy with it. And the challenge is, I think sometimes the trigger can be pulled too early on it. And so the thing now is that I've been always interested in this concept of knee preservation. And that's kind of my practice has always been primarily towards that end. And I work with a colleague of mine called Tim Spalding at Cleveland Clinic London. We've set up the Centre for Knee Preservation. And the whole idea is that there's a whole ladder of treatment that you can implement before you get to a knee replacement. And it is actually interesting that we probably have got a dozen things we can offer before you get to a knee replacement. And at the end of the day, when someone has got end-stage osteoarthritis that is not responding, that's getting pain at rest, pain at night, painkillers, injections aren't helping, then a knee replacement is an appropriate option.
Yeah, and I think that is ultimately the right way to think about this ladder here, is that as much as it is a good operation and has really good outcomes with 85%, as you say, once you've had the operation, you can't unhave the operation. Yeah. So if you do happen to be one of the unlucky 5% or the 10% who don't get so much better, but are kind of the same, then you're in trouble, because then there's no way back. So that's really what we're saying here, is that it's there if you really, really need it. You've exhausted those options. But what we'll cover with time is those other options. But let's go right back to the start. So what is arthritis? Let's say osteoarthritis.
Yeah.
What is it?
So if we look at osteoarthritis, a third of the UK population have some sort of MSK condition, and 10% have osteoarthritis. Not 10%, 10 million have hip and knee osteoarthritis, and about 5 million are living with knee osteoarthritis. That's between 8 to 10% of the UK population. That's a lot of people. And arthritis is quite a broad thing. Majority of it is osteoarthritis, which we'll discuss, and a smaller portion of things like rheumatoid arthritis, inflammatory arthritis like psoriatic arthropathy and these kind of things. But the thing that's interesting about rheumatoid arthritis is that the care and treatment of that has been revolutionized by these TNF-alpha inhibitors, these tumor necrosis factor inhibitors, this kind of injections that came along 10, 15 years ago or so. When I was a junior doctor in clinics, we'd see horrible rheumatoid deformities in clinic. People, with the hands that are kind of gone, and horrible knee and hip deformities. And you just don't see that. Generally, the rheumatoid hand deformed, arthritis mutilans type they used to call, I don't think I've seen in 10 to 15 years. So that side of it's been revolutionized. Although rheumatoid arthritis patients can still get osteoarthritis on top. And osteoarthritis classically has been called this wear and tear disease. That what we do know is that in your knee, you've got the bone. On the end of the bone, you've got the articular cartilage, this smooth lining that kind of has no friction. In between, and you've got that on both sides of the joint, on your femur and your tibia, shin bone and your thigh bone. And in between that, you've got the meniscus, a shock absorber, almost like a rubber ring that just distributes the load. And when one develops osteoarthritis, the cartilage wears away at the end of the bones. The meniscus becomes torn and macerated and chewed up, and sometimes, and what we call extruded. It's kind of squeezed out of the joint, almost like toothpaste. And then the bony arthritic surfaces with the cartilage exposed, the raw bone ends, come together and they contact. And then there is pain on weight bearing. The minute you put together, those bits are just, hitting together and causing pain. And then there is resultant swelling, there's inflammation, and eventually that proceeds to rest pain and night pain. Now, increasingly, I think we're realizing and recognizing that there is a significant inflammatory process to arthritis, and there is a lot of inflammation. And what we're realizing more and more is how much inflammation there is now in the body that's contributing to this. And there are quite complex pathways that are being investigated. But at its broad spectrum, osteoarthritis, whatever the mechanism, and obviously there is a post-traumatic side. Someone has an injury in their 20s, they tear their ACL, they tear their meniscus, they have their meniscus, it is an irreparable meniscal tear that's jamming the joint, so it gets trimmed. They've got a significantly higher.
Yeah, something like 6 times, isn't it? Something like 6 times higher chance of developing knee OA in the future, I believe, with like a ligament plus meniscus, something like that.
Yeah, I mean, there's a recent, Andy Metcalf from Warwick has just published a thing called the Metro study. And the Metro study was it was to do with meniscal tear and surgery versus rehabilitation. But they were looking at basically, and they did a systematic review looking at the outcomes of meniscectomy, and they found that the chance of you needing a knee replacement if you have a meniscectomy in your 30s was significantly higher. No, it was like, and it's either 30 or 300.
Okay.
And that sounds dramatic. It's one of the two. I don't want to say 300 because it sounds so crazy, but that sticks in my head. But it was certainly 30 times more. But sometimes, the challenge I have with patients is I say, look, you've torn your meniscus. And the standard conversation I have before we do an arthroscopy and a symptomatic meniscal tear is, I will always try and repair it if I possibly can. Your risk of osteoarthritis on these kind of long-term Kaplan-Meier survivals, you still have a higher chance if you have a meniscus repair, just having, by the nature you've torn your meniscus, but the repair means your risk of arthritis is much closer to a normal population than if a meniscectomy. There's clear evidence if you have a meniscectomy over all ages, you've got a 20 to 50% chance higher of needing a knee replacement.
And these were getting done like all the time when 10, 20 years ago, right? Probably before that, but I certainly know 10, 20 years ago, everyone had a meniscus tear. That's pretty much the solution.
Yeah.
But
I think for some people it still is. I still think it happens more than you realize.
Yeah.
I'm very careful in my indications. The only time I'll ever operate acutely if someone has a locked knee from a bucket handle meniscal tear. Otherwise, 100% of my patients with a meniscal tear would get referred to physio, a minimum of 2 or 3 months of rehabilitation, possibly a guided injection if there is inflammation in the medial gutter, the deep MCL synovitis, and then after 3 months we kind of have a review. And I say to them, look, at the end of the day, if you are still symptomatic in 3 months, but you can manage it, it's fine. If a certain number of people have a meniscus tear they can live with. There are people playing Premier League football with meniscal tears. But if it is symptomatic, affecting your quality of life, and you can't do the things you do, then we should deal with it.
Yeah.
And sorry to interrupt, but that's the challenge. Because the challenge is that we know that if we do a meniscectomy to someone in their 30s, they are much higher, much more likely to need a knee replacement in their lifetime. And it may be 15, 20, 30 years away, but the flip side, the balance is, but for 20 or 30 years, they can be active, they can play football, they can do triathlons, they can do all the things they want to do. And so it's balancing that quality of life versus, what may happen in 20, 30 years.
I think all it is you've got the opportunity now to give people the choice. Say, here's the data, here's what it means. What do you want to do?
Yeah.
You could choose this path or you could choose that path. Whereas, as you rightly say, the bucket handle big ones, they don't really have a choice because they've got no function in the knee. It's just too much. So with those ones, it's different.
They will never heal. And if you repair them, then they get remarkably good level of function. And it is, the goal is always to repair a meniscus. I reckon I probably repair 30 to 40% of my meniscal tears. I'm really aggressive at repair, and we have newer techniques now and newer surgical equipment to make repair more likely to be successful, more robust, and we can now enhance it better with biological means of giving it a better chance of healing. So I'm very aggressive at repair if I possibly can.
Well, it comes through again, joint preservation. You're really thinking of long term. And let's just track back to something else you mentioned earlier about essentially the definition of osteoarthritis being a very structural definition. Now, as we both know, the structure does not necessarily mean the symptom. So there's a huge chunk of people out there who have really ugly looking knees and could be easily diagnosed osteoarthritis on a scan. Yeah. But they walk around, run around, play sports, and they don't complain of anything. So what's going on there? Is that where we start to think more about the inflammatory nature of what's happening, do you think?
So there's definitely an inflammatory nature to it for sure. And I think that, and the thing that you know better than me, and probably most of your listeners do, is the muscular support around the knee has a huge role. I saw a chap yesterday in clinic who's 43, and he's got advanced trichomotor osteoarthritis, which is what's reported in every MRI scan you ever see, but they don't tend to have it. But this guy genuinely has, and he had meniscectomy 15, 20 years ago and has advanced arthritis. He's seen 3 knee surgeons and been offered knee replacement. I saw him, and his symptoms didn't quite match the MRI, and so I sent him off for rehab, quite intensive rehab, and he has come back, and he's just ran 5K at the weekend. He's did one of those high rocks events. High rocks is causing so many knee injuries, it's unreal. I don't know much about it, but it's It keeps him busy. And then the chap came back yesterday and he is flying. And he's not had an injection. He's literally asymptomatic. I discharged him. And of course, I suspect he will come to having intervention. But the fact is, you're right. He's probably one of the worst x-rays I've seen this year. And yet his symptom levels are of someone who's of really low level, just twisted my knee and now I'm better.
This is where, as physios, I think we get to pat ourselves on the back occasionally, because we can turn what looks like a no hope zone into something that's like, wow, you've got a real chance of living a really good life again. I'm thinking of cases off the top of my head here where people come in and they've given up all sorts of sports in their 50s and sometimes earlier, and you just say, well, what if you just try something? What's the worst that's going to happen? You're lining yourself up for big knee surgery anyway, so what about if we just try something? 6 months down the line, they're getting back to tennis, they're running again, and they can't believe that their knee can handle it, because their previous belief model was that I've got a joint that is completely shot. I've got bone on bone. There's no way I can do whatever I want to do. And for some people, that is the truth. They struggle. But other people, they could do really well. So you just need to give them the choice, I think.
I think the challenge is how you phrase it. So bone on bone is probably one of the most damaging terms that we have in orthopedics, because it paints such a horrific picture of, bleeding bone ends rubbing together. And actually, structurally, it's not far off that. But the fact is, the psychological damage that does to patients, I don't use that phrase. And if we just phrase things differently, see, I say to people that your normal knee joint can take this amount of load. This is your load, the load tolerance. Actually, it was a phrase that James Noak introduced me to, load tolerance. So that's your normal load tolerance. When you have damaged, you've got osteoarthritis, you've lost meniscus, you've lost cartilage, the joint, your load tolerance is down here compared to normal up here. And then the fact is that, but just by rehabilitation and all the kind of non-operative things that we're going to come to, you can bring that level up. It's not going to be normal, but it's going to be better than it was. And then the question is, what does that look like for you? So for Charlie Goodchild, what does that look like? I go, well, okay, that I can cycle as much as I want. I can swim as much as I want. I can get the weights, no problem. Okay, 5K once a week, great. 5K twice a week, fine. If it goes beyond that load, say 5K and a 10K, and it's too much for your knee, your body will tell you with pain and swelling, you rest it, you ice it, you back it off, and then you go again and you just recalibrate and titrate.
So I'd even add some nuance to this, because I'm convinced, by the way, that James Noakes stole this off physios. This low tolerance concept. We speak about this all the time.
Do you?
But James Noakes, I mean, by the way, excellent. One of my favourite sports med doctors. I refer to him all the time. And he was on our podcast, actually.
Was he? Yeah. Oh, fantastic. But he's never had an original thought in his life.
Exactly.
So now it makes sense.
So what the nuance, in my opinion, here is that it is low tolerance in a way, but it's actually the inability to recover at the same rate is the problem. These joints, that the cartilage surface is no longer as pristine as it once was. They just take longer to recover.
Yeah.
They have more inflammation after exercise that takes more days to recover. So it's exactly right. You can often get someone back running once or twice a week. The impact load just takes 3 days to recover. Once someone goes above that, you tend to see that they struggle.
I don't tell people not to run. From a structural point of view, you can't particularly make it any worse, and so live your life and do the things that feel comfortable. I've never told anyone not to run. Now, there are certain things, if you have isolated patellofemoral osteoarthritis and you're doing heavy weighted squats beyond 90 degrees, you're running up and down inclines, that's not sensible. But by modifying so many things, you can still do the things that you want to do. So I've never told anyone not to do anything, which I think is a thing that some physios get upset with surgeons for. And I say, find your level, find your load tolerance, and work within that.
And there's often the scope to progress. You just have to progress a bit slower than most people, and you may have to accept the ceiling is a little lower, like we said earlier, for your end goal. But as long as you provide enough recovery and allow enough of that, then they tend to do pretty well here. And what I think is fascinating, and the more I look into knee arthritis, well, arthritis in general, is that ultimately the cartilage is designed to take compressive load, right? And it responds really well to that. So it has this adaptive nature. If you compress it nicely, then it actually becomes really strong and robust. If you overdo it, of course, you can cause an injury. If you underdo it, it actually gets weaker. It starts to atrophy.
Yeah.
So this is why it's relevant when we start talking about is running good or bad for knees and hips. And the studies essentially show that moderate running, kind of recreational running, is safer than sedentary for knee arthritis. So sedentary people get arthritis at about 10-ish%.
Right.
And recreational runners get knee and hip arthritis at 3%. So it seems to be protective. So that compressive load with enough recovery, some recreational running was 2 to 3 times a week, I believe. So with enough recovery actually is protective, just like going weight training, you build your muscles up.
Yeah.
Running seems to be nice and strengthening for the knee.
And the value in loading your bones, in bone health, muscle health in particular, mental health, just the psychological release that people get from running. There's so much value in that, that telling people not to do that has a myriad of impacts that go well beyond just my knee hurts less. The one thing we do know is that running on a swollen knee is not a good thing.
Absolutely. Yeah. And ultimately that is, tell us, do you know structurally any kind of details here? Because this is what I'm really interested in. And as a physio that deals with post-ops, that's the bit you're careful of, is when you've got a swollen knee, you just got to be cautious about that compressive load and the impact loads.
So in the way that you put your eye waters, if you irritate your knee waters, it's creating cushioning in a way to try and keep the bones apart when you haven't got the cartilage and meniscus to do it. So it's like a protective evolutionary mechanism the knee has. The problem is within that, there is a lot of pro-inflammatory cytokines. And the challenge is that inflammation can actually weaken the cartilage and attack the cartilage. And I've seen quite a few cases where people have been running on swollen knees, not quite a few, but a few, where they've literally dissolved away the rest of the cartilage. They've just chewed it up, chomped it off. And that's the concern that we have with running on a swollen knee. But if you haven't got swelling, the benefits of running, you know better than me, are untold. Yeah,
and I've shared a few patients with you where this has been the case as well. Is the challenges of reining people in when they have that swollen knee is tough, and that people don't often understand that. They just think, just push through. And with certain MSK conditions, that actually is the answer. Tendons, largely, you just have to push through at the right level.
And osteoarthritis, I often say, look, if you want to do impact activities, so a lot of the time, I'm telling people, it is funny, but the vast majority of consultations I have are me basically explaining the clinical examination findings and an MRI often findings, and saying, well, look, the challenge is we have 3 Tesla MRIs. They're so sensitive. They pick up so many things. Number one, with a history and examination to go, right, ignore that. Grade 1 MCL, thickening proximal MCL, forget that. Your knee's completely normal on exam and you have no MCL symptoms. Almost everyone who's done sport has got a grade 1 MCL on an MRI. Forget that. Fat pad impingement, don't worry about it. Forget that. And my job is to basically interpret it. And honestly, at least 5 consultations at clinic I just want you to know that your knee is robust. There's inflammation in your knee. You've fat pad inflammation, a bit of synovitis, a bit of patellofemoral. There's inflammation. There's no structural damage. Your knee is strong. Your knee is robust. And nothing that you have done so far to this day has caused any permanent damage in your knee. When the inflammation goes away, your knee is normal, and you'll be able to get back to whatever you want to do and have that confidence. And so we have that conversation quite a bit. And that reassurance is definitely what a lot of people need.
What a powerful thing to be able to do, and a powerful message to come from a surgeon, for them to go thinking, bloody hell, mate, I might need to have surgery here. And for you to essentially weigh up all those things and balance them off and say, looks okay, you need to carry on.
Totally. And then honestly, a lot of the time my job is to go back to the physio and do what they told you to do in the first place. But people understandably want that reassurance. And so I'm very comfortable to give it when it's appropriate. And often it is.
Yeah. And on the other side of it, the ultimate truth of cartilage is that it doesn't grow back in the way a muscle and a bone and they don't repair in that way, and a ligament. Yeah. But there is a level where they can adapt still. That's my true belief, is that once you shave it away, it doesn't grow back to the same level. But even ugly looking cartilage that's arthritic can still become more robust, and that comes through a rehab process that's careful and that means that you don't load onto inflamed knees and strengthen the muscles around it to ensure that it can handle more. But I really believe that it has the ability to kind of adapt in its own way, just nowhere near as fast, nowhere near as completely as some of the other structures in the body.
So the thing that we do know is that there are certain surgical techniques that can allow some cartilage recovery. There is a thing called distraction osteogenesis, chondrogenesis, which we don't do, but they've done it in ankles before. They have done it in some knees, where basically you put a frame, a bit like, the circular frame, a bit like a bicycle wheel around the knee. And if you jack out the knee, and you're certainly the ankle as well, you jack it out, cartilage can regrow. But no one's going to tolerate having that frame on, for 3 or 6 months. It's a nightmare. The other thing, and the most powerful tool that we probably have, is osteotomy. So we talk about this concept of joint preservation, and in joint preservation, there are 5 things. Well, actually 6. Number 1 for me in joint rehabilitation is in joint preservation. Number 1 is physiotherapy and rehabilitation. Number 1. Second thing is, and then we go to the surgical elements, as it were, alignment. And a lot of people are malaligned. Let me rephrase that. A lot of people have alignment that is not straight down the middle. They may not be malaligned for them. A lot of people are in varus. They have bow legs. You know, we know that makes you a much better footballer. High chance of becoming a professional footballer.
Could change your direction.
Yeah, and it gives you speed. And a lot of people have this constitutional varus. So a lot of people have bow legs, but often it can be excessive. And if you've got medial compartment damage with bow legs and you've lost some meniscus and cartilage on the inside of your knee, 80% of your body weight every time you load goes through the medial compartment that is now degenerate, then we know by doing an osteotomy, sawing through the tibia, straightening the bone, putting a plate on it, you move the line from the medial compartment to the center of the knee, or perhaps a little bit beyond. And that is remarkably powerful. That reliably will give you 8 to 10 years further out of that knee before you need to just consider any sort of surgical intervention. So say rehab number 1. Number 2 is alignment. Number 3 is ligaments, because you need to have a stable knee. So you're going to make it stable if they're not normal. Number 4 is meniscus, restoring meniscus. And the last thing is articular cartilage.
Let's go back to number 2 there. So the osteotomy. So it's no joke of a surgery. I mean, it's a pretty big one. But the difference is it doesn't really go near the joint per se, does it? It's below. It's the tibia.
Yeah.
So what's going on there, I guess, is that it opens up space. Just like you said, it's like a pseudo distraction type technique, right? It shifts the dynamics in the joint, and that space then allows. I guess what we're coming almost to is that the body essentially hates space, doesn't it? It doesn't like a vacuum. It'll fill it with something. That's what osteophytes are. It's like it's trying to fill space.
Yeah.
So perhaps what's going on there from what you're saying is an element of grows a little bit of cartilage perhaps into that space. I don't know.
You'll be surprised the space by doing the osteotomy, you don't increase the space. You'll just remove and I don't think anyone's ever seen that happen. All you're doing is you're moving the weight bearing line to the bits of the knee that are completely normal. Yeah. So it's almost like, let's say you've got a car and you're driving on 2 wheels. You're just going to balance it, put it over 4 wheels, perhaps more towards the tires with good pressure. But I do a lot of revision ACL reconstruction, and a lot of the time the patients have malalignment. If they are not straight, the weight bearing line is not through the center of the knee, and they've torn their ACL, then you have to correct that first. So you correct it with an osteotomy. In certain patients, I'll do that and I'll fill the bone tunnels with bone, and then I'll bone dowels or bone graft, and I'll say we'll come back after 1 year. After 1 year, we'll take the plate out, and then we'll put the new ACL in. We might often do a lateral tenodesis with that. Now I've seen dozens of patients who've got grade 3 to 4, and just for everyone listening, when we grade cartilage damage, we grade it from grade 0 essentially, which is normal, to grade 4, no cartilage, the bone is exposed. And so grade 3 or 4 means you've really quite far along. You've virtually lost, or you have lost all your cartilage. And I've seen dozens of patients where they're grade 3 or they're grade 4, and I do that. I go back a year later, take the plate out, scope the knee, and there is some cartilage there.
This doesn't get spoken about enough, and everyone's doom and gloom. The cartilage never grows back to any level at all. And I've been feeling and sensing that there's a bit of a shift that's coming, and by the sounds of it, you're open to the idea that there is this possibility that under the right environment some cartilage can grow back.
It's all about load, and so putting the biomechanics right is absolutely key. And before we do an osteotomy, we will try people with offloader braces. We may give them orthotics to try and simulate that or give them that benefit. And so there are things we'll try before osteotomy, and osteotomy is getting better because now I'm doing quite a bit of patient-specific osteotomy, which is where basically they have a very specialized CT scan. A custom jig is made. You literally, on a 3D model with the engineers, you go, I want it there. I want that angle, both on the front view, the coronal view, and also on the side view, the sagittal view, because there's a thing called slope that's becoming more and more of a problem now. The slope of the tibia, the angle on the side, is very much linked to ligament deficiency and ligament injuries. And so we do this called a biplanar correction, where you correct it not only front on, but side on as well, which is really quite complicated. And we've always done it by eye, by some pre-op planning, but now there are kind of quite specific patients with jigs you put it on. The cuts are built in, the screws, it tells you what screw size you're going to use from the beginning. And it's quite, and that's just making it even more accurate. So I'm thinking that, and I'm feeling that osteotomy, and it's always been around in orthopedics, but a lot of knee surgeons don't do it. I'm not claiming anyone, a lot do, but the fact is I think it's really growing in importance and people are doing it more and more.
So let's move to number 3 now, which was the ligament reconstructions. Yes. And there's clearly a place for ligament reconstructions. There's also an argument where people are saying, do we need these when we look at the long-term data regarding osteoarthritis? What's your take on the counterpoint to knee ligament reconstruction?
The challenge with literature that we have is, and I'm an academic, I'm an associate professor, and yeah, I find there's lots of challenges with literature because there are papers that show that ACL reconstruction categorically stops you getting arthritis. And there are papers that show it makes no difference. And so, and we don't have a clear answer. And and if a patient asks me, will this stop me getting arthritis? I say, I can't tell you that because there's no evidence. What I do know is that if your knee is giving way and you're having repeated instability, then each time you have a giving way, this pivot shift, you can damage cartilage. It is not a massive injury that chips off a huge bit is very rare. Repeated wear is quite possible. And as you twist and it gives way, you can definitely tear menisci. And losing meniscus is they have a huge load bearing and proprioception and and a lubrication synovial benefit, and so losing those is an issue. So I'm more concerned about people getting future meniscal tears and cartilage wear than saying you're going to stop you getting osteoarthritis. But the number one thing is if someone's symptomatic of instability, we know from the ACL SNAP trial that surgery is a safe thing to do, and it is far superior to rehabilitation alone. With an ACL, it was published in the Lancet. I don't know if you've seen it.
Yeah.
So, and basically ACL SNAP, and we don't publish in the Lancet, orthopedic surgeons normally. This is a level, it's kind of probably the highest impact factor journal in the world. And so to get in there, it's going to be really robust trial. So multi-center, randomized control trial, 600 patients over 28 hospitals, and basically a non-acute ACL injury, so more than 4 months old, which I'd say is probably acute in most people's books. And if if you torn your ACL more than 4 months ago and your knee is giving way and it's unstable, surgery is superior to rehabilitation alone, and we know that for a fact.
I think we're comfortable with that actually, really. And again, it's that subtle thing of the nuance of giving way, instability. I mean, yeah. I'd be pretty concerned about any patient of mine whose knee was giving way, let alone why it was giving way. Well, there's something going on there, and if I can't solve that with some kind of quadricep loading, because it may be pseudo giving way because the quads are insufficient. But if it's not that, then I'm going to be sending them off to a knee surgeon for consideration. So I guess the trick here is really being able to identify the ones who definitely need to speak to a surgeon versus the ones who may do well with rehab, which ultimately it sounds like it's the giving way concept. And if we then go back to what you said, the giving way is the bit that's causing the micro, sometimes macro damage to the cartilage, which is then going to either give you short to medium term problems, or by the sounds of it, the long term problems. Yeah. And when we said earlier, when you remove bits of meniscus through a meniscectomy, they've got a 30 to 300%, whichever the number is. I need to find the number. I'm risk of knee arthritis.
Yeah, Andy Metcalf's going to kill me.
Or total knee replacement.
Total knee replacement. Andy Metcalf's going to kill me because I can't remember the number. Let's go with 30, but I think it's pretty drastic. And the thing is that if it's just an ACL and they are stable and they do the rehab, they get back to do what they want to do, absolutely fine. I've got plenty of patients to do that. If I may be honest now, I think coming to a physio-based podcast and to say that actually, in my experience, I probably see 5 to 10 ACL ruptures a week for sure. Those who get back doing everything they want to do, the rehabilitation alone, is not a huge number. But I appreciate I may be biased because some of them may not be coming to me in the first place. But the ones that I say go away and have 3 months physio and come back, there's not many. A handful a year, I think, if we go, I'm actually fine, I'm back skiing or doing what I want to do. Yeah. What do you tell me? Because there may be some you don't send.
Yeah, and perhaps if they do really well, they don't need to come back and let you know as well. I think that's part of it too. And there's this expectation factor as well. The ones who expect they're going to need the ones who expect they're going to need surgery, they're the ones who tend to end up needing surgery because they never fully trust. And we know a predictive factor for successful return to sports is trusting and confidence in your knee. So if they believe they need surgery, they don't ever fully trust it. So that's something that I really take into account when I'm listening to the person in front of me.
And there definitely are people who come in and go, a lot of patients who are non-medical, they say, I've torn my ACL, I want it reconstructed because something is not right and it needs to be made right.
Yeah.
And I have a conversation with them. There's this classic group of, the group of threes that we talk about for ACLs, where people go into three groups. One group will do the rehab and get back to doing pretty much whatever they want to do. In my personal experience, that's a really small group. There's the other extreme, the group whose knee is so unstable that it gives way in the street, stepping on and off a curb. That's very rare. And most people, 85% plus in my experience, in the middle group, which is actually they'll do the rehab, they'll get back to all straight line activities, they can run, they can walk, they can cycle, they may even do some gentle pivoting, and they're absolutely fine. And they've got a decision to make. Either then they go and do pivoting and the knee gives way, a lot of them actually go, I don't want to take that risk, just reconstruct my knee. And, very happy to do that, an appropriate, prepared, rehab consented patient.
Yeah, because the thing that most people take for granted here is how demanding the rehabilitation process is post ACL reconstruction.
Yeah, I've been doing ACLs for 10 years now as a consultant, and every single month I appreciate it more. Because it is not 9 months and you'll be back to playing football, which is what it's sold as. Even 9 to 12, it's not that. For sure, you have your ACL done between 6 to 9 months. I expect to be running. Most people won't have the strength, the control, or the confidence to go back to any sort of pivoting sport at 9 months.
Yes, I normally say, look, it's minimum a year, and you're probably looking a bit longer. Certainly, if it's multi-ligament or meniscus involvement, probably looking at 18 months.
And I think, if I'm honest with you, I think we understand the literature that 18 to 24 months is the recovery time.
Yeah. It's also reduced risk of re-injury. The longer you leave it, the better. So if you're not in a rush, then take the time.
2 years is the sweet spot.
Yeah.
The fact is, people don't want to wait for that. And so for somehow, it looks like it's just been halved from 18 to 24 down to 9 to 12. No one at 9. If you're a professional athlete, professional footballer, you operate on those. It's your job. You're getting 6 hours, 8 hours of physio rehab in the gym a day. Someone's massaging your scar for 40 minutes a day. Then the fact is, 6 to 8 months is quite reasonable. But for anyone who's not a professional athlete in full-time rehabilitation, it takes longer. I still think the results can be outstanding, but the thing that does make me slightly sad is there's some people who I think had a really good operation, who've done really good rehab, whose knee feels rock solid, not symptomatic. Go, actually, I'm not going to bother with football now. You must see that a lot. I don't want to risk it anymore.
Yeah. Or the other sad group, which we also know in the literature, is the ones that then go and do the other side fairly soon afterwards.
Yeah.
And that's a tough one, isn't it? Because I had one a year or so ago, and he absolutely nailed his rehab, did so well. Both sides were looking really good, stronger than ever, change of direction, confidence was there, which took a while. And I think 18 months in, he was, almost a session before going back, and he ruptured his other side.
That's disastrous. And, in that situation, you would take into account so many factors, so increasingly in that patient, you look at their alignment. You would never do an osteotomy primarily off the bat for someone with a first-time ACL rupture. I was speaking at a conference in Barcelona recently, and we put a straw poll of some of the most experienced knee surgeons in Europe. And not one person said they would do a primary osteotomy if someone was bow-legged and they tore their ACL to make them straight before they did it. But if they tore it again, of course you would. And if they tore one side and the other side, then if they've got a history, if they're hypermobile, you might consider it. If they've got a family history, or if they have this thing on the side view of the slope, the tibial slope. If your tibia is just too steep an incline, your femur falls off the back. Yeah. Your tibia gets pushed forward.
So you can never be strong enough to resist the gravity of the slope, essentially.
Yeah. The bone rules everything. Yeah. And so those patients, so there are some scenarios where we might consider it, but it's not the standard in any way.
And we're going off topic, I guess, a little bit, but actually it kind of isn't, because the ACL being a factor for knee stability is relevant to the preservation of the health of the joint here. So we'll stay on it just for a moment longer.
My favourite topic. I love talking about ACLs.
Yeah, me too, to be honest. I'm very comfortable here too. So what about the ACLs that repair? Not long ago we thought that they were all doomed, but now we're seeing incidences where they do repair themselves if given the opportunity, and there's brace protocols to enhance the chance of that. What's your thoughts on that?
I was really hoping you wouldn't ask me about this, because I'm now going to get absolutely destroyed on social media and kicked out of town. I strongly believe that the ability of the ACL to heal by itself is extremely low. I have not seen any patients who have been cross-braced. that is a protocol, as you know, where they fix 90 degrees flexion for, is it 12 weeks?
Yeah, it looks really annoying.
I mean, that's miserable, right?
Yeah.
12 weeks.
Yeah.
And my understanding is it's still 50% of those crossed over to surgery. And there's different concepts here. So on an MRI scan, you're lying on your back. There is no force on your leg, tibia at all. The fibers can just look like they're in a normal position. And I've seen people who have relatively look normal, who've not been braced, who look like they've had a pivot shift injury, have got symptoms of ACL instability, and on the MRI, the knee looks pretty stable or a partial ACL. You examine them and do a Lachman test, and in the MRI, they're just flat. The minute you put anterior draw on the tibia, comes up here, or you do a pivot shift test, which I'm doing increasingly in the clinic, and they're rotationally unstable. And on it, I can think of 2 or 3 occasions in my career I've seen what I consider an ACL healing.
Okay.
But they weren't braced, so
yeah.
I haven't seen that side of it.
So I guess there's a potential, there's a bit of an optical illusion on some, but
Yeah.
and then it's as everything. You've got to combine the clinical examination with the patient's symptoms.
Yeah.
Maybe they're still giving way despite the look of the MRI.
Yeah.
With the scan. So
and there's 2 bundles to the ACL, you know. So you've got your anterolateral and your posteromedial bundles, and the thing about those bundles is that the anteromedial bundle controls your anterior draw and your tibia coming forward on your femur, but the PL bundle controls the rotational stability. And you can have patients who are stable front to back, but twisting causes instability, and vice versa. And you can't tell that from an MRI.
it's had the clinical exam then. That's a pivot shift.
Yeah.
Lachman's.
Lachman, pivot shift, anterior draw, and also the patient's clinical symptoms.
Yeah. Okay, so it sounds like most people who have certainly a multi-ligament, multi-structural knee injury would need some level of knee preservation, stabilization surgery.
Totally.
From your perspective there. And if they have that, you might even consider an osteotomy for someone with alignment problems, certainly a second ACL by the sounds of it as well. You might start looking at family history and looking at whether they might need something else in addition to it. There's also the tenodesis as well. So that's something that I probably only came across maybe 5 to 6 years ago actually as a concept. So some people need that. So why would someone need an extra bit of stability from this tenodesis?
So you were well ahead of the curve, because I don't think I heard about it until about 5 years ago. So one of the most impactful papers in orthopedics in the last 50 years, I believe, is the stability trial. Al Getgood from London, Ontario, did a multi-center randomized control trial, multiple countries, and in their study, 18 to 25-year-olds with a ruptured ACL, unstable, and it was a hamstring ACL versus hamstring ACL plus a tenodesis. A tenodesis, or an LET, a lateral extra-articular tenodesis, is a reinforcement down the outside of the knee. It's an extra-articular reconstruction, and it is almost like a seatbelt to protect the ACL. It is an 6 to 8 centimeter scar on the side of the knee. It takes about 10 to 15 minutes to do. The morbidity from it is not huge. But in this group of 18 to 25-year-olds with a hamstring ACL, the re-rupture rate went from 11% down to 4%. And we know from biomechanical studies that a lateral tenodesis reduces the force on your ACL graft by about 51%. I think it cost them $200,000 to do that first paper. And I think almost every knee surgeon, certainly sports knee surgeon in the world, is doing now lateral tenodesis. So for £200,000, something that's changed practice is unreal. People have spent millions on studies that have achieved nothing. And so it is a hugely powerful thing to do. And I use tenodesis quite a lot. So the patients that I'll use it in, for instance, so I think someone's between 18 to 25, strongly advise it. And all I ever do is advise. I give them the option. It's their decision. I never force it upon anyone. But the paper is clear, 18 to 25-year-old, it's a strong thing to do. It's someone who's hypermobile, who's got natural joint laxity, whose tissues are going to stretch, it's worth considering. In someone who's going to high-level pivoting activities, elite sports, certainly professional sportsmen, I would do that. Even semi-pros, I would do that for. People who've torn an ACL before, I do it with all my revision ACLs. I would add in a tenodesis. And in someone who's got a family history, I had someone whose 4 brothers had torn their ACLs, and I was like, all of them, and I was like, okay, well, let's add this in. And it's, as I say, a lever on the outside of the knee that stops external tibial rotation, stops you going too far, so the ACL never gets to the point where it can stretch and snap. And there's lots. The thing that's interesting is there are several different ways to do it and to achieve it. And some people do a thing called an ALL reconstruction, anterolateral ligament reconstruction. But the stability trial was purely a lateral tenodesis using a strip of your iliotibial band tunneled under your lateral ligament. And now on the basis of that $200,000 study, they've got $5 million. Now they're doing stability 2, which is now looking at a patella tendon versus quadriceps tendon, which is a new fascinating thing, plus or minus LET. And that's the paper. To be honest, I honestly that paper for the patella tendon versus quads tendon angle, but they're adding LET to that as well. Yeah,
I had a patient, Deepu Sethi. He did a quads tendon for one of my patients a few years ago.
Yeah,
and she did really well. She was great. I can't remember the exact indications. You'll probably know better than me, but it was the first one I'd seen, and she ended up doing great.
So I probably do about 10 to 15% of my ACLs are quads tendon now. Probably started about 2 years ago, and really pleased with it. Of course, for me personally, I use it where I would use a patella tendon previously. If I was doing a revision ACL, I think I'd still take a patella tendon to have the bone blocks for some more rigidity, quicker healing. But in a patient who I think who I'm not going to use a hamstring graft for, I'll use a quadriceps tendon graft. It's usually about a 3 centimeter incision above the knee. The concern is that it can switch off your quads for a bit. Yes, for the first couple of weeks for sure, but not much more than what you'd get from a tourniquet.
They do it anyway.
Yeah,
as you know, from all the big swelling in the knee, the quads are going to disengage anyway. So you go through the same process from what I would.
Not much different, and I find it a much more robust graft. There's been a lot of pressure to use it. Interestingly, as in America, the numbers have skyrocketed of quads tendons. It gives you, what the thickness is with the hamstrings. You take the size that's there. There are lots of tricks and ways that we have to make it a bigger, thicker graft. But the quads tendon, you set the size. Like the patella tendon, I'll take a 9 mil, I'll take a 10 mil. We know from the Moon Group study that an ACL graft smaller than 8 mils is 8 millimeters in circumference is associated with high risk of re-rupture. So I'll take a 10 mil quads tendon, fix it there. And the thing that's really impressed me with that is that it is absolutely rock solid when they come back. You do a Lachman, it's almost grade 0. So, but it's not for everyone. But I'm using it increasingly, and I'm intrigued to see data, more information come out on it.
So now we've got we'll move surgery to one side. I reckon we've done a lot about ACL there, osteotomies, and some joint preservation options. So what about the person who? It doesn't seem like a good surgical candidate. They have signs of osteoarthritis. What are the things that you might be advising them and telling them to do to keep them out of surgery and to optimize their joint?
So imagine osteoarthritis for me comes in three tiers, 3 levels. Level 1 is the first thing is rehabilitation, coupled with strength and conditioning. Work with physios, work with strength and conditioning coaches, work with PT. That is key. We talk about weight management, and increasingly we know that weight is a significant impact on the progression of osteoarthritis. Talk about weight management. Activity modification is key. We go back to that load tolerance idea where modify activities to avoid the things that cause pain and swelling and reduce it accordingly. Build up your strength, build up your tolerance, then go back and introduce the things slowly and find your ceiling. And the ceiling, as you say, is dynamic. With that comes appropriate footwear for activities. Silly as it sounds. And then beyond that, we're talking about things like splints and braces. You may get an offloader brace. You may have some kind of a splint or an orthotic, an insert, an insole. We talk about painkillers. Painkillers are paracetamol is a remarkably effective drug for osteoarthritis. You add in anti-inflammatory such as naproxen or celecoxib or ibuprofen. I do say to people glucosamine and chondroitin sulfate. I do recommend that as a supplement.
I wasn't convinced by the studies, I must say.
Yeah.
I think when I've looked at them, and perhaps not in a huge amount of detail and a long time ago, it just seemed like it was not much difference.
And I would agree with that. And I'm not kind of claiming otherwise. I think the evidence is weak. There's no detriment to it.
Yeah.
There is suggestion of some benefit. And so on that basis, I say to people, look, if you can afford it, in the way you would take a multivitamin, just add it in some people taking fish oil. Thank you. It's not my first language. Fish oil capsules, things like that. I take glucosamine.
Yeah.
I've got nothing wrong with my knees, and so I agree the evidence is weak, and it's not enough to justify prescribing it to everyone in the country with osteoarthritis for health economics reasons. But if you can afford it, take it. And then those are those things are really important. So physiotherapy, weight management, appropriate footwear, modify your activities, painkillers if you need, supplements. And there are other things that are weaker evidence. Acupuncture is kind of sponsored in the NHS. I've not seen great.
Yeah.
Have you seen much benefit with it?
No, I just think acupuncture is a short-term pain reliever that can work for some people, and it seems to work on the people that have a belief that it's going to work on them.
Yeah.
So, I mean, I have no qualms in people doing it, because a bit like the glucosamine chondroitin, it probably doesn't have a negative effect.
Yeah, for sure.
But there's people who will have it and go, that didn't work, and you go, well, don't use it then. But there'll be people who come in Swear Blind and say, acupuncture is the thing that gets me through my week. It's like, well, it sounds like you should be doing acupuncture, right? You have a measured approach with it. You don't get in the way of people's placebo and responses. And there might be some other stuff going on, and I'm not convinced personally that there is. But placebo is strong enough. Placebo is a huge pain reliever for many, many people, and I'm not going to be the one that gets in the way of that.
Yeah.
What I'd like to come back to is your second point there, is the weight management thing. Because I reckon most people go, yeah, that makes sense. Load on a joint we need to offload the joint with less weight. But my understanding is that it's not as simple as that, and that weight management is working in a different paradigm. It's not necessarily biomechanical load all the time. There is probably an element of it. Yeah. But it's the systemic load that is causing due to the inflammation of being either overweight or obese.
Yeah. The more we understand kind of and get to know about metabolic syndrome and inflammatory conditions, being overweight is associated with all these things. High chance of getting diabetes, high chance of being in a metabolic syndrome, and causing a systemic, more like to have inflammatory cytokines and chemicals in your body that are going to attack the lining of the joint and advance that. But at the most basic level, we know that when you squat, when you run, when you come downstairs, when something between 8 to 10 times your body weight goes to your patellofemoral joint, if you weigh 10 stone, let's call it, it's 100 stone, right? There, that if you're, and so you increase that weight proportionally, the load does go up. I'm not claiming that it necessarily causes it to erode away quicker or to do that, but it will cause more pain.
Yeah, and I think the other part is that, as we know, and we spoke about, referenced this earlier, symptomatic osteoarthritis versus non-symptomatic osteoarthritis can look the same on a scan.
Totally.
So therefore, the weight management might then make some sense. If we're talking about it as a purely offloading concept, then we wouldn't then be able to understand why these ugly looking joints feel fine. But if we think about it from an inflammatory perspective, it starts to make a bit more sense, because inflamed versus non-inflamed does seem to be related to symptoms.
Which is why people take anti-inflammatory medication, anti-inflammatory injections. So, but I'm saying if you add the weight in with all the other myriad of things that we're offering, and the challenge is I'm not sure people really buy into doing all that, all of those things that we mentioned as kind of tier 1, stage 1 management. But if they do, then weight management is a key part of that. And we just know that it has so many benefits for your health,
Then if we look at, you mentioned briefly their injections. So what are the kind of things that you offer people or talk to people about regarding injections for arthritis?
So when it comes to injections, that's kind of the stage 2 treatment, where now you're intervening in somewhere, you're sticking something in. And in terms of injections, broadly speaking, historically, there's been a steroid injection, a pure, cortisone, as it were. People, a corticosteroid injection as a pure anti-inflammatory, which has benefit in an inflamed knee. The challenge with that, injecting into an arthritic knee is okay. The challenge with injecting into a normal knee is that there is evidence that steroid is chondrotoxic and it can kill cartilage cells. And so if I use it in a normal knee, I'm using it to put a fire out. I'm using it for pes bursitis, medial synovitis. We're targeting something that's on fire, one and done, cure, put the fire out. Repeated injections into the knee can damage cartilage. If someone's already lost cartilage and they've got arthritis to help manage their symptoms, that's well worth it. The risk profile is low. The benefit may not be great. You can get a steroid flare. I've never seen an infection. It's a theoretical risk. a steroid flare is the thing. I think last time I saw one genuinely is before COVID, but boy, it's not fun when it happens. The people, more pain, more swelling, red hot, it caused a lot of challenge. But actually, it's remarkably effective injection for many people the first time, but it's a law of diminishing returns. You will have seen people who get 3 months pain relief out of their first steroid injection, a week after the second one, 3 days at the third one, and then it just stops working. And I'm careful not to start injecting people's knee with steroid because I tend to find a slippery slope. The minute I start that one injection, you're essentially starting the clock on a knee replacement, is how I view it, so I don't rush into it.
So how do you get across? Because I bet you get people coming in and going, I've tried everything, I just want an injection. What's the kind of way that you converse that with a patient? Because it's delicate, isn't it?
So I'm really comfortable. It's a safe thing to do, but it may not be effective. And I do feel as if we're kind of firing the starting gun now on the time towards your knee replacement. And so I need to make sure that the history, the examination, the imaging confirms that diagnosis, and that they've done everything in stage 1 treatment that they possibly can to offload it. And all the things in stage 1 can be remarkably effective. When someone comes to you and they are struggling, then we talk about injection therapy. So steroid we talked about. The other thing is hyaluronic acid. The challenge once you get into this kind of others is that, that when so many studies comparing to placebo are mixed, hyaluronic acid, theoretically a synthetic or naturally occurring joint lubricant, it does not work very well in advanced osteoarthritis. When you're stage 4, when it is exposed bone, doesn't work so well. In kind of grade 3, slightly earlier, and this anecdotally, I've seen some very good effects, and I've seen no effect. But I've had people 12 to 18 months of symptom relief, and then come back later for a second one. But the evidence is not strong. Some of the insurers now aren't covering it. We still have it in the NHS. We still do use it. So for me, kind of conceptually, hyaluronic acid is for a grumbling knee that's not full-blown end-stage osteoarthritis. Steroid is for an angry, inflamed osteoarthritic knee that they just need some symptom relief. And the number one goal of the symptom relief for me is to allow people to then engage better with their rehabilitation and get back to it. It's not just to make their pain go away. Yeah,
trying to kick them back to stage 1.
Yes.
And give them that window of opportunity. We've used this term a lot. And I think the challenge is really engaging someone in that process when they're in pain relief states, because ultimately they just want pain relief. So they get pain relief, and it's easy for them to kind of go, well, job done, I'll leave it. So it's really key getting that communication across that, right, this is a window of opportunity, and we're trying to, as you've said, put the fire out. Whilst the fire is out, let's build the tolerance, build the stability, because we've already spoken about the dangers of an unstable knee. So there's too much torsion on the cartilage. Cartilage likes compression, not torsion.
Shear
force. So if you have a rehabilitation journey that focuses on stability and builds, I mean, this is all conceptual. It's hard to prove this stuff, but we know that rehab works. We're not fully sure why, but we think there's an element of stability coming through from better muscular control and proprioception, all these things,
and strength.
But better strength. We improve the load capacity of the knee via the muscles. So I think there's huge benefits to be had. But the problem is the people that drop out of the system after getting pain relief. So really, what we're getting at here, I guess, is that the stage 2 is there to kick people back in stage 1.
And the challenge that we have, so my NHS practice is at Barts in London, and the challenge we have there is that there is an epidemic of knee osteoarthritis in the country, and it's growing. If you look at the numbers of people getting osteoarthritis, it's off the chart. It is linked to rising obesity rates, it is linked to inflammatory lifestyles, but it's off the charts. And quite soon, the estimates are that we're not going to have enough surgeons available to treat the number of people in the knee replacements.
Well, I'd even add on enough physios who know what they're doing in order to develop the stability.
We really don't have enough physio. And the biggest challenge we have in the NHS is rehabilitation, because there's so many people, a lot of it's done in classes. The patient engagement can be very mixed. People have personal lifestyle pressures that not everyone can afford to give up an hour a week to multiple times a week to focus on their rehabilitation. Not many people have access to a gym or a swimming pool, outside of confines like this.
Yeah, and like it is, you can do home-based programs quite well, and gym definitely helps. Having access to equipment helps, but you need a clinician or a coach or a trainer who knows how to adapt the environment for you to design a plan around an individual. There is an off-the-shelf concept that can be beneficial for a good chunk of people, but there'll be some that need it to be really bespoke to them in order for it to be effective.
And a lot of patients come in the mindset that injection is for pain relief and it's not to facilitate the rehab. I do really try and push that, but so many are just, pain's gone away, I'll keep going until it's time for my next injection. And it's very hard within a limited time consultation to break down someone's life-held belief that may have been passed down communities and generations.
Yeah, which is what I think the physio's job is, really. If you can get them into the physio's room, then that is our job. We are trying to motivate behavior change. We have a longer time. We have rehab-specific tools to our disposal. We can measure things and show people the differences.
Yeah.
I think our job really as rehab specialists is to motivate people towards that part of the journey. So you're almost being hard on yourself there. I think you do a good job anyway, but it's once they're with us, then we have to get to work.
But the challenge is our physios, there are not enough of them, and they're overworked, and they have far too many patients to treat, particularly in the NHS. So that is a challenge. So we talked hyaluronic acid. The third thing that we can inject is PRP. Plasma, platelet-rich plasma. Every single time I say it, I get the wrong way around. And so it is a blood test, take blood from the arm, spin it in centrifuge, take out the good stuff and inject that in. The evidence for that is incredibly mixed. There's lots of different flavors of PRP, dozens of flavors of mixtures of types, leukocyte-rich, leukocyte-poor, various things. And if you look at every systematic review meta-analysis, there is essentially overall, and I'm generalizing here, no difference between that and placebo.
Yeah. I remember sitting in a conference and Kareem Khan, who's a very well-respected clinician.
Is it BJSM?
Yeah, standing up and just showing the difference and saying, and there was this big reveal, and the big reveal was, this was like 10 years ago, the big reveal was, it doesn't work. And I'm sure there's some nuance to that, and there's clearly some studies out there and many clinicians who do use it. But the big stuff doesn't seem to show.
It hasn't really changed.
Yeah.
And now the thing is, they're now second generation PRP coming out. So there is a proprietary one from a company called N-Stride. N-Stride is kind of a second generation PRP. Essentially, they inject from the plasma, they inject good cytokines. I'm really simplifying here. The good cytokines, interleukins, TNFs and various things into the knee, with the idea that will then replace some of the bad cytokines and negate them. That has quite early promising data. My colleague Tim Spalding does N-Stride, and anecdote. So he collects all his data. Tim is meticulous. Tim is a machine. He collects all his data, follows patients up. I've started doing the same because we're partnered now. And in his experience, there's a 7 out of 10 chance on a paper on stuff that he's collected on data that the patient will respond to N-Stride, and the people that do will get a minimum of 18 months of significant symptom relief. But of course, that's one person's study. It's not the bigger. But N-Stride is one, and then obviously there are newer things such as arthrosamid.
Yeah, and I've spent some time working with Contura, the company that produced that, and just by accident I had a case who had tried the HA injections, had multiple steroids, and had only ever had the short-term relief. And he was a young knee arthritis case who'd had previous surgeries, wasn't a good candidate for any further surgeries, was running out of options, and just so happened to get introduced to them. This was quite early on in their development, and he flew himself out to Denmark and got this injection. And this guy was skeptical as well. He was like, "Oh, it's not going to work, is it? But I've got no other choice. I'm going to go. I'm happy to spend the money." And off he went. He came back, and neither of us could believe the response it had. Like, this is absolutely N=1 anecdotal, but he just had such a great response to it that lasted for well over a year. And I was tracking his data. I was tracking his pain. I was tracking his strength, his muscle size, and all of it just kept getting better and better and better. And we'd worked up to that point about 1.5 years, maybe even 2 years. He was with a colleague of mine before me on trying to get him back after his original surgery. And every time he would make some progress, he'd go back. So this was a guy that was just not progressing, had all the motivation in the world and not progressing. Yeah. He had it, and it settled down, synovitis in his patellofemoral joint. He just flew from there. So as a result, I got introduced to the company, and they I've worked with them a little bit since, and it's interesting. Like, I've seen some interesting data. My gut feeling is it is early, and there'll be some people who wouldn't be willing to speculate on the amount of money it will cost for an injection like that. But yeah, that's probably my experience with Arthrosamid.
So Arthrosamid is this kind of non-biodegradable gel. It's 2.5% polyacrylamide, 97.5% water, and it is kind of 1 ml injection. They inject into the knee. It started off used in horses.
Yeah, racehorses. Yeah.
Racehorses, the thoroughbreds. And it then was used in humans as a bulking agent in the bladder for urinary stress incontinence, and it's kind of now made its way into joints. The postulation is that injecting this, that it integrates into the synovium, helps with shock absorption, and it helps with viscosity in the knee.
Synovitis, I believe, is their main reason now. So to bring, and they believe its indication should be, if you've got a synovitic knee not responding to normal methods, then their feeling is that it's an option. It's a joint preservation or trying to avoid surgical options type option.
And as a surgeon, I'm always looking for ways to avoid surgery. Some of a thing that I'm really mindful of with regards to Arthrosamid is that it never goes away. When they've done biopsies in horses and rabbits, I think they introduced it in, it's still in the synovium. There was a study where some people had Arthrosamid, humans had knee replacements, and they biopsied the synovium and it was still there.
They call it an implant as a result.
Yeah. So you have to treat it as an implant. So we have to give prophylactic antibiotics as we would for a knee replacement. And I'm not quite sure what the long-term effect of that is, because it's always there. Our biggest concern when we do a knee replacement is some sort of foreign material or infection. I'm not saying it causes any more infection, but there's something else there. And so I'm taking a wait and watch approach with it. We do offer it at Cleveland Clinic London. People have to, it's a self-pay only thing. No insurer covers it. My understanding across London, generally speaking, it's £2,500 to £3,500 an injection. At Cleveland, we've got one person administering it, a sports and exercise physician, under ultrasound guidance, with antibiotic cover, and we're collecting all the data. And we have, a research nurse who collates all that data. So we are doing it in a controlled and responsible manner, but I'm not in a position where I would recommend it off the bat to anyone. And if I've got a young person in their 30s who's got advanced osteoarthritis, which happens occasionally, it's not common, but it happens, and they've tried everything, then there'll be a discussion to be had about Arthrosamid for sure.
Yeah. This is my case, ultimately.
Yes, absolutely. Case, And that's kind of, for me, is that's kind of tier 2 of treatment when it comes to managing osteoarthritis. In ideal world, we want to stop people getting there, because we can sort the alignment, sort the ligaments, sort them and replace the meniscus if we can, transplant it, do a cartilage transplant of some kind. The goal of knee preservation is to do all that to try and prevent it coming on. But once it's established, then yes, we're going through these stages that we're discussing.
Kash, is there anything else that you would add into the mix that we've not covered today regarding knee osteoarthritis?
No, I think the only other thing that I mentioned, that there have been various trials of joint distraction devices. There was a thing called a kidney spring, which was basically you take the condyle and the tibia, you screw a thing in above, a thing in below, and you turn this dial to distract the joint. And we know that distraction can work, but that a big bulky thing under there has, and unfortunately, they didn't work. And I suspect that someone will come back to us with another version of those to physically crank the joint open and take that pressure off and stop it touching. And there's been a few of those over the years, and I suspect that idea will come back, because conceptually and biomechanically, that idea still
I heard
hits.
I can't remember who Tonya Vincent, her name was. I can't remember her exact specialty, but she looks at things on a cellular level. And I remember hearing a podcast where she spoke about this being a concept, and they did it in rats and mice, I believe, and they kind of distract the joint, and it does seem to show some cartilage growth fills the space. So obviously, as we've said already, that doesn't necessarily transfer over into humans, but by the sounds of it, you're curious about that potentially working in the future as well.
For sure. I really understand from a biomechanical point of view that there's value in that. We haven't had the implants to make it work, and I'm not sure there's anything brewing, but it will come back. It will happen again in a lifetime. And the other thing I want to make point is that we talk about tier 3 of treatment, knee replacement. The fact is, it comes in various flavors. I'm a big fan of partial knee replacement. I did my fellowship at Oxford, where they did the Oxford partial knee replacement. My dad's got one in, had it done last year, he's delighted. A partial knee replacement in the appropriate patient is a really effective operation. You leave the ACL in place, they've still got proprioception and control. With a mobile bearing with an Oxford, where normally with a knee replacement, you have metal on the end of the femur, metal on the end of the tibia, and a bit of plastic, poly insert in between. That's fixed. But with the Oxford, it slides around and there's a bit more flexion. There are very good, since 2003, we've collected all our data in the UK on the National Joint Registry, and there are other types of partial knee replacement. There are fixed bearing that do remarkably well, made by other companies. And a partial knee replacement for the right patient is a really good operation. That's particularly on the medial compartment, which is the majority. On the lateral compartment, slightly less so. And then the patellofemoral joint replacements, the experience has been mixed. And then when it comes to joint replacements, total knee replacements, there have been improvements in design, and obviously now there's a concept of robotic knee replacement. We are certainly at Cleveland Clinic London, we're doing lots of robotic knee replacements. In the NHS, I'm not sure the health economic argument is there at the moment.
So there's lots of options, I think. We opened up this conversation saying that we wanted to be hopeful about this, and there is a lot of hope. There's clearly more work. There's always more. I mean, we could literally use that label for everything. More research needed, but it seems pretty optimistic for people if they follow those tiers that you've advised there, at any level for any severity of arthritis. So that's my thought. Is that I was hoping we would get there, and that hope is the ultimate emotion here. And there's options.
It is, and for me, I think what I just want people to get away from is, I have arthritis, I have an injection, I have a knee replacement. That is very simplistic, and there's so many things in between. I think more we can push people towards the left-hand side of that journey, the better. And as knee surgeons, that's what we want to do.
Absolutely. Well, how would someone find out about you, Kash? I know we've already said that you host a podcast, a very good one. So
yeah, if people look up Orthohub, go into Spotify, Apple Podcasts, YouTube, we film them as well, if you really want to see us, but most people listen. Orthohub, it's a light-hearted conversation. There's a lot of messing around. You listen to some.
I have, yeah.
And we don't take it too seriously. We talk about lots of different aspects of orthopedics and increasingly about health. Our last one was about microbiome. We've got one coming up on sleep. And so it's fascinating conversations. And I'm on Twitter and Instagram at Kash Akhtar. You'll have to look in the show notes because you can't spell it, but I'm there.
And what does better never ends mean to you? So your final question, I'm going to put you on the spot.
So this is interesting. When you first told me a few years ago this is what I'm setting up, I really didn't understand what it meant. And I was talking to James Phillips and Nick Guth, we were having a coffee. And then I genuinely didn't get the term at all. And I thought, what the hell is it? It makes no sense. And then I went, oh, right, now I get it. Better never ends. It's a continual journey of improvement, and you can keep going. And then I finally got it, but this is maybe 2 or 3 years after you set it up. So I'm sorry for being so dense.
I love it.
You were playing 4D chess and I was just playing checkers.
Yeah, I think it's probably the first time that I've been considered to be smarter than you. So yeah, let's go with that.
I'm sure it's not the last time. But no, thank you for having me, buddy. I've really enjoyed it. I love the setup here, and I hope that's been of value to people.
Yeah, thanks for coming in.
Thanks, buddy.
Thanks for listening to today's podcast. This podcast is sponsored by Better, provider of health, wellness and performance services based in central London. You can book in for face-to-face services at either of our 2 clinics, one in Soho and one in the city. You can also follow us on Instagram at Better Never Ends, or head over to our website for more information about the clinics or the podcast at www.betterneverends.com. And of course, if you want to send us an email with any feedback, questions or suggestions for future episodes, then email us on podcast@betterneverends.com. And finally, thanks to Brian Long for editing the show. Without him, it's absolutely no doubt in my mind that these would never have seen the light of day. And it will allow this podcast to continue on for as long as I'll keep recording them. So thanks very much, Brian.